very much. So this is wonderful. I have the last two presentations. I'll only keep you for 2 hours, not too long. The first talk is targeted agents in gastric cancer. We'll talk briefly, very briefly about chemotherapy and highlight some of the points that Dr. Lordick made. And then we'll talk about known targets, HER2 and EGFR you heard earlier today, anti-angiogenic therapy, which has been discussed before, c-Met, and just touch on Hedgehog. But there are other targets as well, as you just heard from Dr. Van Kutsum. So this is a table from a recent publication reviewing common 3-drug and 2-drug regimens. And the highlight is to indicate that median survival for most patients with gastric cancer is still less than 1 year. This, of course, does not include patients who are HER2 positive that get trastuzumab, where median survival actually surpassed 1 year. But up until then, up until that single study, all phase 3 studies have demonstrated, at least for non-Asian studies, have demonstrated a survival of less than 1 year. So we really clearly need to do better. This is the TAX-325 study that demonstrates the superiority of the addition of docetaxel to cisplatin 5-FU versus cisplatin 5-FU alone. And the difference is marginal, at least at the median, maybe half a month, but at the tail of the curve you see a more significant difference where you have nearly a 20% 2-year survival versus a 10% 2-year survival. So there really clearly is a role for taxanes in this disease. And then this is the REAL-2 study looking at different regimens involving epirubicin platinum and fluoropyrimidines. And ultimately, the study demonstrated that survival was less than 1 year. Perhaps EOX is better than the other regimens, and when compared to ECF specifically, it was superior. So challenges in targeted therapy in gastric cancer. One of the main challenges is what is the best chemotherapy backbone? Dr. Lordick very nicely outlined the data involving anthracyclines and taxanes and doublets. You know, I think that if you are not going to use a targeted agent, certainly if someone has an adequate performance status, a 3-drug regimen would be superior. However, what 3-drug regimen would you choose? Right now, we don't understand the biology of gastric cancer well enough to pick one over the other. I think that's the future, that we need to understand that better. But the other thing that's very important is when you add a targeted agent to a 3-drug regimen, it does actually matter because of overlapping toxicity and tolerance. And then the last point to make in terms of a challenge is what type of gastric cancer should we treat? Gastric cancer is not one disease, and that will be the topic of my next lecture. So let's talk about some specific targets. This is the EGFR family of receptors, HER1, HER2, which is in the open configuration, HER3, and HER4. And let me just take 1 minute to describe how this works. So the ligand for HER1 or EGF, for example, will bind into this pocket here, and that results in a conformational change where this binds to this, thereby opening up this active moiety. So you'll notice that HER2 is always open. This is the active site, and so it's a ready partner for any other EGF receptor. HER3 and HER4 both have ligands as well. So the activation of this pathway is dependent on binding of EGF to HER1 or one of the herregulins to HER3 or HER4 to turn on into an active receptor moiety these receptors that then either homodimerize or heterodimerize with another receptor. And this is the TOGA study, which is now well known to everybody. 3,800 patients were screened to identify 800 patients that were HER2 positive, resulting in a rate of HER2 positivity of about 21%. 584 patients that were HER2 positive were randomized to receive chemotherapy. The backbone here was capecitabine and cisplatin. either with trastuzumab or without trastuzumab. And then this is the top level result. Patients who were HER2 positive and were randomized to receive Herceptin did have a survival advantage, living nearly 14 months, so more than a year for the first time. Patients who were IHC2 plus, FISH positive, or IHC3 plus even had a better benefit, living up to 16 or 17 months. So that's quite astounding. The TOGA study met its primary endpoint, prolonging survival by about 3 months at the median level, p-value of 0.0046. It reduces the risk, Herceptin reduces the risk of death by 26% when combined with chemotherapy. The secondary efficacy parameters were met, and there was no additional toxicity. So based on these results, Herceptin is now approved nearly across the globe for the treatment of HER2-positive gastric cancer. What about another EGF, another receptor? Let's look at EGFR1. This is the study that was done by the CLGB and ECOG in North America. This was a randomized phase 2 study looking at 3 different arms of chemotherapy. One was ECF plus cetuximab, one was irinotecan and cisplatin plus cetuximab, and the other was FOLFOX plus cetuximab. So the rationale to use cetuximab is that EGFR expression is overexpressed in esophageal and gastric cancers, correlates with prognosis, adverse prognosis in upper esophageal adenocarcinoma and squamous cell carcinoma, and KRAS mutations are few, less than 10% of esophageal cancers. So there's good rationale because there would be few patients that have intrinsic resistance because KRAS positivity. These are the results. So the progression-free survival of the 3 arms was about the same. So just to point out that every arm received cetuximab. So we're not looking at the benefit of cetuximab, we're looking at the chemotherapy backbone here. And although ECF and FOLFOX seem to do better than irinotecan and cisplatin in this randomized phase 2 study. And the median progression-free survivals are nearly 6 months or 6.5 months versus 5 months for irinotecan and cisplatin. And then overall survival, similarly, irinotecan and cisplatin did poorly compared to either FOLFOX with cetuximab or ECF with cetuximab. And then with regard to toxicity, each of the 3 arms had some toxicity, moderate toxicity, total about 80% on the 3 arms. ECF with cetuximab had a high death rate, which I think needs to be explored a little bit further. We don't have the final report on this study. Irinotecan and cisplatin, as you might expect, had a significant GI toxicity and electrolyte abnormalities, whereas FOLFOX had primarily neuropathy. So what did we learn so far? All 3 regimens had a response rate of greater than 40%. Irinotecan and cisplatin seemed to have the lowest response rate and the lowest survival and more adverse events. So ECF plus cetuximab had the highest response rate, but also the highest treatment-related mortality, which I'm not sure is valid, but possibly given what we know about the PRIME study. FOLFOX plus cetuximab had a good response rate and survival and seemed to be the best tolerated. So that leads us directly to REAL3 and EXPAND. REAL3 was epirubicin, oxaliplatin, and Xeloda plus or minus panitumumab. And EXPAND is cisplatin, capecitabine plus or minus cetuximab. So I'll talk about REAL3, which was presented by Dr. Waddell at ASCO just earlier this month. As these investigators were beginning this study, they actually embedded into this a dose-finding evaluation because they realized that there was increased toxicity, specifically diarrhea, with full dose of EOX. So dose level 1 right here is the standard dose of EOX, epirubicin 50 milligrams per meter squared, oxaliplatin 130 milligrams per meter squared, and capecitabine 1250 milligrams per meter squared. And panitumumab was the standard dose of 9 milligrams per kilogram. And ultimately, the dose that they moved forward with the phase 3 study required a reduced dose of capecitabine and a reduced dose of oxaliplatin, as was mentioned earlier by Dr. Lordick. So, and the top-level results do suggest that there was reduced efficacy, not improved efficacy, but reduced efficacy of chemotherapy, at least EOX at reduced doses, plus panitumumab versus EOX standard dosing. 37% higher risk of death with the addition of the targeted agent. So what do we learn so far? HER2 is a validated pathway and target. That's clear. EGFR is not yet a validated target in upper GI cancers. We await the results of the EXPAND study. Accrual has completed, and we should get the results, I think, in the next 6 months. But it highlights the point that Dr. Lordick made earlier. The chemotherapy backbone does matter. It matters not only when you're looking at chemotherapy by itself, but it matters also when you're looking at combinations with targeted agents. Moving on to anti-angiogenic therapy. This is an old slide, but I like to show it because it's dated from 1939. And it highlights that anti-angiogenic therapy, or the concept of this, has been around for a very, very long time. So this is a tumor that's in the earlobe of a mouse. And the technology in 1939 was to essentially look at photomicrographs of the earlobe, which is very thin, and you can see the blood vessels and you can see the tumor. And as this tumor was growing, the investigators saw these blood vessels kind of grow into this tumor, creep into it. And they had this quote in the article: "One is almost forced to conclude that there is, associated with viable tumor growth, some blood vessel growth stimulating factor." Had they just named it VEGF at that time. So the rationale for targeting anti-angiogenic therapy. Tumors require new blood vessels for growth. In preclinical models in gastric cancer, anti-VEGF therapy slows tumor progression and is synergistic with cytotoxic agents and irradiation. And in human tumors, VEGF is overexpressed in many tumor types. It's associated with malignant progression, and inhibition of VEGF is a promising anti-cancer approach. So there are many, many reasons to try it. This is a recent publication of our modified docetaxel cisplatin 5FU regimen with bevacizumab. This was a phase 2 study of 44 patients. It was published last year in the JCO. And the high-level results were that in this selected single-arm phase 2 study, it was a 2-center study, median survival was 16 months with modified DCF and bevacizumab. There are many other studies, phase 2 studies, that also demonstrate activity of chemotherapy with bevacizumab. We performed the first study with irinotecan and cisplatin and bevacizumab, and for the first time we had a median overall survival of over 12 months. I just showed you the modified DCF results, and then another investigator published docetaxel and oxaliplatin with bevacizumab, and there have been other studies as well. Based on these phase 2 studies, Roche supported a international phase 3 study of bevacizumab in combination with chemotherapy as the first-line study in advanced gastric cancer. This was a double-blind, placebo-controlled trial. Stratification factors were geographic region, the fluoropyrimidine backbone, and disease status. The design was very similar to the TOGA study. The reference arm was capecitabine and cisplatin and placebo, and the experimental arm involved bevacizumab. This is patient accrual across the globe, and more than half the patients came from Asia. And in my next lecture, you'll see if that matters or not. Europe had about 33%, and in North and South America was about 15%. And these are the overall results. So the addition of bevacizumab with chemotherapy yielded a overall survival of 12.1 months, not too far off from the phase 2 studies. Chemotherapy alone, 10.1 months, which is similar to what we'd expect for chemotherapy alone. However, the p-value was 0.1, the hazard ratio was 0.87, and it crossed the 1.0 boundary. So this, at least for overall survival, it was not significant. There were significant improvements in progression-free survival and response rates, but not in overall survival. So this was a negative study, at least for the primary endpoint. So in the face of the compelling phase 2 data, in the face of the compelling data in other GI malignancies, how did we explain the AVAGAS results? One answer might be a biomarker answer. So this was the largest phase 3 study to prospectively require tissue for biomarker analysis, and that's, I think, a compliment to Roche for pursuing that. And this was a study that was just published in the JCO, which is the first biomarker analysis for gastric cancer in over 700 samples of patients. And this is a forest plot which is taken from the paper. It's a bit complicated, but I'd like to focus on two biomarkers. One is tissue VEGF-A. And here you see that this is broken up in quartiles. So the lowest quartile, the second lowest, third highest, and highest quartile. So as VEGF-A increases, you see a potential, as VEGF-A decreases, you see a potential benefit, and as neuropilin, you see a benefit in the low neuropilin group versus the high neuropilin group. So plasma VEGF-A as a potential biomarker, this is the progression-free survival curve from the paper. And so patients who have a high plasma VEGF-A and receive placebo had the worst survival, and the red dashed line is patients who had a high plasma VEGF-A and received bevacizumab. So bevacizumab seemed to overcome the high plasma VEGF-A levels. And then similarly for neuropilin, patients who had low neuropilin, less than the median, had the worst outcomes unless they received bevacizumab, and then they had the best outcome or better outcomes. So these are two potential biomarkers that need further validation, but they are very close to being very significant with regard to prediction of patients who might benefit from bevacizumab in gastric cancer. Just a word on c-MET. We heard the nice presentation earlier today. The rationale for MET in gastric cancer. So the MET gene amplification is reported to occur in about 10 to 15% of patients, perhaps less than 10% in Caucasians. A germline mutation in MET was seen in at least one gastric cancer kindred, and the MET protein and transcript is overexpressed in sporadic gastric cancer. It's associated with more advanced disease and worse survival, as we've seen just earlier. This is the MET pathway, so it's driven by hepatocyte growth factor here, and then it activates MET, and then through GREB2 and SOX, you have activation of PI3 kinase and AKT that promotes cell cycle, and through the RAS-RAF-MEK pathway, you get cell growth. So you've seen these results of the AMG 102 study. Relatlimab is an antibody against hepatocyte growth factor, so it will inhibit MET signaling that way. And this was a randomized phase 2 study that showed a benefit of relatlimab with chemotherapy versus chemotherapy alone. These are the combined arms of a low dose and high dose of relatlimab. The blue line is. And then more interestingly, in the MET high group, which is a small group to be sure, you've seen this curve earlier today, but the green arm has 11 patients in it, and it is associated with worse survival. The median survival is 5.7 months. So it suggests that, at least in the very, very small subset of patients, high MET expression may be associated with a very adverse prognosis. And in that population, it suggests that an antibody against HGF might actually provide a benefit. And so the investigators, at least Amgen, is moving forward with a phase 3 study to follow up on this. And then just a word on hedgehog signaling. So this is the hedgehog, so I'm not actually sure how the hedgehog pathway is named after this hedgehog, but it's a signaling cascade that is evolutionarily highly conserved. It's important in embryonic patterning, and it's also important in the stem cell response to tissue damage. And there are 3 mammalian genes. There's the sonic hedgehog, Indian hedgehog, and desert hedgehog. And this is the hedgehog pathway. What happens is that you have, my pointer isn't working, you have patched, which is on the cell surface, and when it's activated, then smoothen is actually intracellular, but when you have hedgehog signaling on the right, that binds to patch, and that allows smoothen to come up and come into the surface, and that also frees glee as an activator. And when you have glee activation, you have activation of many target genes. You have activation of cell cycle genes that are important in proliferation. You have activation in stem cell signaling network like JAG1 and Wnt signaling. You have activation of or upregulation of stem cell markers as well as genes important in EMT, epithelial mesenchymal transition. So finally, there's a correlation between glee expression and lymph node metastases, at least in gastric cancer. And so there's significant rationale for examining a hedgehog inhibitor in gastric cancer, and that was done in a randomized phase 2 setting with modified FOLFOX, and that was a US study as well. And that study has accrued, and we will have results of that in the next 6 months or so. And that had several correlative studies. So my summary points. Drug development in gastric cancer is challenging. The median survival for most patients is less than a year. I think we need to focus our efforts on 2 fronts: understanding the target and disease biology specifically, and then optimizing the drug with the acceptable chemotherapy standard, because there's diversity in which drugs we would choose. I also think that the future of drug development in gastric cancer is promising because there are many more agents and many opportunities for us. And with that, I'll thank you.